So we are all walking a path which together to finally succeed and render the best palliative care service to the needy. That's our main aim and goal. My sincere regards and respects to Dr. M.R. Rajagopal. He is the founder chairman of Palim India, and it's a big pride, privilege, and pleasure to introduce him. And for the whole batch, I would say it's a pride and privilege to have this session being done by him. He is the person who took all the initiative to remove all the barriers as much as possible, regulatory barriers or any other hierarchical barriers, whatever was there in procuring morphine. And he had a long road, but he has made procurement much, much easier for us today, so that which is considered as the gold standard for pain relief to be provided to the patients or whoever needs it. Okay, so he is going to be taking you through the session today and introducing what palliative care is, so that from day one you all know and understand it very well, and by the end of the course you will be willing, eager and efficient to practice it. In 2014, the International Organization of Human Rights Watch honored him with the Alison Despoges Award at Los Angeles. And in 2017, a Moonshine Agency released a documentary film, Hippocratic 18 Experiments in Gently Shaking the World, which revealed what all are his contributions to palliative care. And in 2018, Republic of India, the Indian government honored him with Padma Shri. And last, what I'm going to say is the best, last but not the least, as we say. He has published a book, Walk with the Weary, in 2022, which is a worthwhile read. With that, I hand it over to you, Dr. M.R. Rajagopal, to kindly take us through this session.
Yatha, thank you. Sri, are all the participants from within India, or do we have guests from abroad?
Sir, all the participants are basically Indian citizens.
Okay, very good. I don't know, Sri, I think at some point of time you should consider adding a 15 minutes to the first session, just to get to know people. Like I see that we have some 45 participants here from various parts of the country. It's a shame that I don't get to meet them as person to person. See how serious everybody is looking. Hey, ladies and gentlemen, please give me a smile. That's a lot better. See how the screen is getting cleared up, lit up. Thank you. Oh, we do have very important things to talk about. Nevertheless, there is no reason why we should not enjoy learning. So friends from across the country, glad to have you all here. Radha and I are both anesthetists by training. You must be coming from a variety of disciplines, many fields in medicine, general practitioners, internal medicine people, oncologists, anesthesiologists, so many. But friends, and of course, I'm sure there must be some dental surgeons also in the group. But whether we are MBBS or BDS, irrespective of the fact that we are the specials that we are essentially human beings. That's a generic name, despite all the degrees. sometimes the pressure of work and the weight of the degrees, every degree becomes an added weight here. Have you noticed how people stop smiling when they get more and more degrees? Have you noticed how muscular rigidity sets in when you get degrees? The more super specialized you are, the more rigid you are. I think we need to remind ourselves that we are human beings, and as healthcare providers, we have to think what our primary responsibility is. Even if you are a neuro-ophthalmologist, we still are healthcare providers. In the country in which Radha is sitting now, that's in the UK, the duty of the healthcare provider is defined by law, not in our country. We don't have a law covering that. But in the absence of law, what holds validity are documents created by any statutory body of Government of India. And one such statutory body is the Indian Council of Medical Research. And ICMR's Bioethics Unit has defined the duty of care of the healthcare provider, not only doctor, any healthcare provider. Hey, somebody wants to take a guess. What's the duty of the healthcare provider? Can I pick up some random name and ask? Dania Xavier and Dinesh Power. Want to take a guess? What do you see? I mean, in your mind, if you think, what do you see as your duty of care to? If I am your patient, what's your duty of care to me? It doesn't have to be Dania or Dinesh, anybody. Does anybody want to offer a comment? You can unmute and speak or put it upon the chat box. Sri, will you please monitor the chat box?
To address the patient's problems and to treat the patient.
Problems.
Make them comfortable, sir.
Sorry?
To make them comfortable.
Yes, absolutely. I agree. Parvati says
somebody has put in the chat to ease suffering.
That is Parvati. Okay. Bhargav Dev says you have to inquire into the reason. Now, that's very interesting. Dr. Bhargav Dev, we want to know the cause of the problems, but only with a view to relieving the problem, right? Why, Dr. Bhargav, what specialty do you belong to? What do you do? You want to unmute and speak? No, okay.
Dentist, yes,
okay, dentist. Yes, Dr. Bhargav, I'm saying that with a specific reason. Sometimes we want to know the cause of the problem, even when we know that there is no solution in sight. Can I give you an example? Suppose somebody has a malignancy, maybe maxilla, and it's advanced. So advanced that we have pronounced that there is no treatment. Still, academic curiosity may force you to ask for an MRI scan to see if there is an intracranial extension. Even if there is an intracranial extension, it is not treatable, in which case I wouldn't do it. So totally correct, doctor. It is to know the cause of the problem so that we can relieve it. And as Shikha says, addressing social, psychological, ethical, and physical problems, and also and physical problems. Yes, ethical. I would add spiritual. Yes, Sanoop. Hey, Sanoop.
Yes, sir.
What are you doing here? You have done this course many times over, haven't you?
Yes, sir. I thought I'm just simply sitting, so I thought I will join.
Look at people coming back for another course. Dinesh, deliver quality healthcare. Dr. Dinesh Power, that brings in the question, what is healthcare? Very complicated. We'll come to that. Good quality of life. Amanjeet Kaur, good quality of life. I mean, all the answers put together would be very good. But Sanoop has come to the official definition of ICMR. The duty of care, ICMR says, is to mitigate suffering. It is to cure sometimes, to relieve often, and to comfort always. That's a 14th century aphorism. And ICMR adds, there exists no exception to this rule. Friends, there exists no exception to this rule that your duty is to mitigate suffering. When possible, that includes curing. If not, it includes symptom control, but always comforting the patient. Does anybody have any comment about that? Are you able to accept that your primary responsibility, whether you are an interventional cardiologist or a general practitioner, you have the primary responsibility to mitigate suffering, means preventing and treating suffering. And of course, the investigations that are necessary to do it, provided the investigation does not make sure that the children of the family go hungry. That also we'll consider. The thoughtless MRI that you may write to look for intracranial extension may mean that there is no food for the family. And I have actually seen a person with advanced malignancy in Tamil Nadu, in a city bordering to Kerala, where a person with advanced cancer, very advanced cancer, was taking one capsule a day, which was prescribed to him by a cancer center. It cost something like 84 rupees a day. And this was for a man who had no income. And the poor chap believed that it was something to treat his cancer. Multivitamin mineral thing. So we'll remember this all along. I hope we will remember this through our lifetimes to mitigate suffering. But unfortunately, in India, 7 to 10 million of us, there is almost 1 crore of people, are in serious health-related suffering. If today I use the acronym SHS, it stands for serious health-related suffering. Sri Priya will be sharing this presentation with all of you. This document, as well as this, are both available open access on the internet. In both, if at all you can find a little time, 15 minutes each, at least read the executive summary. It will be very useful. So friends, the 45 of us who are attending this session, we are together going to relieve a huge chunk of this suffering. The issue is global. Not only India, we know, but it is mostly in low and middle income countries where management of diseases, this is frightening. India is one of the worst countries in the world as far as catastrophic health expenditure is concerned. 55 million Indians. Again, I have given the reference. This is also open access, and we seldom think about it. This is not so in the same in every country. But look at the numbers. With all our degrees, the collective work that we are doing is driving more than 4% of the population below poverty line every year. Many of them climb back above the poverty line, but not all. And very often the next and the subsequent generations also get destroyed. Before you pick up the pen to write that prescription, pregabalin, or something expensive like that, think again. And please remember that palliative care is not for any particular disease. I'll stop the screen for a second so that I can have your attention. Among medical professionals also, very often there is the wrong belief with that palliative care is only for cancer and AIDS, that palliative care is only for dying people. You would not think of discriminating anyone in the name of age, sex, or caste or creed, right? Would you? But we seem to have no qualms about discriminating in the name of a diagnosis. Some are high caste, we letters them. Others get rejected. That's unfair. Now, this document from the Worldwide Hospice and Palliative Care Association, again, the link is shared. This is called the Global Atlas. Of all conditions necessitating palliative care, only 28.5 are cancer. A large number, remember dementia. Oh my God. If God comes to me tomorrow and tell me, Rajagopal, its time has come for you, you choose. Do you want cancer or do you want dementia? I wouldn't waste a second. I would grab the cancer. I don't want dementia. Some of the worst suffering is caused by CNS disorders. Heart, cardiac diseases, lung disease, liver, kidney, etc., etc., etc. So, first point is your primary duty and mine is to relieve suffering. Second point, whatever disease condition causes suffering, we should be there. Friends, that gives us an additional problem that you will not find in the textbooks. Sri, will they all get the Indian primer? Sri? So
Sorry, sir, mic was muted. I was talking all the way. Yes, sir, they will get the soft copy, definitely.
Okay. And if anybody wants a hard copy, you will tell them how to get it from you, right?
Sure, sir. That will also be arranged.
So that's an Indian document, a book. But any international document will show you things only that are proved in UK or France, Canada, USA, or Australia. Only high-income countries. Our problems will not be written there. When I say our problems, we have so many, including have you seen children with burns? No, we only children or adults. The kind of lives they are forced to live for months, it's not a chronic disease. And I would refuse to show my hands if somebody wants to handcuff me with a definition saying chronic diseases. It's not there in any definition. If there is suffering, if we can do something, we should. So this is a Western thing. What I'm saying is in our country and in rest of the developing world or low and middle income countries, which is 85% of the world, there are many situations that cause suffering, which you will not find in the textbooks. And remember, the suffering in our country is so bad that according to data from the National Crime Records Bureau, more than 29,000 people in India kill themselves for health-related reasons every year. And think for a moment, a majority will not even get into our statistics. In the villages in UP, Bihar or Jharkhand, do you think they'll get reported even? And for every person who succeeded, they get into the statistics. For every person who succeeds, how many dozens will be trying and failing? In palliative care, we see this very often. At one time, we used to see scars around the neck. Now that happens less often. Now it is futile attempts at slashing the wrist without studying the anatomy. And for every person who attempts it, how many will be living with the feeling, if only I had the strength to kill myself? These are stark realities in our country, from which you so far could run away. But now that you have chosen to learn palliative care, you cannot run away any longer. There is more bad news before we come to the management. Hey, can you read this? I don't have to read it. Friends, the 45 participants here, I don't know which one of you is going to be my physician tomorrow. I don't know who will treat me. I hope it is one of you. I hope you will not allow this. But even if you are not able to treat my suffering, please do not inflict this kind of misery on me. Ventilators are important. Intensive care is important for people with salvageable conditions. In the context of inevitable death, in the context of futility of treatment, this is an obscene violation of human dignity and all justice. When I say this, I am sure that I must be causing pain to at least 5 of the participants in the group. If there are 45, at least 4 or 5 would have had the experience of a loved one in your own family being subjected to this. It's almost taken as the norm. I see Dr. Vasantha Raghavan nodding. Yes, Dr. Vasantha? You are muted, Dr. Vasantha.
I object. I didn't want her to go die on the ventilator. So I just no need to turn on ventilator. Silence. Just pain-free. Sleep itself, she passed away.
Dr. Vasantha, you are able to talk about it now. You are able to talk about it with some peace on your face. Those who have gone through the other painful experience may not be even able to talk about it. So we'll talk more about it when we discuss, when myself or somebody else discusses end-of-life care. But please see this. The National Cancer Grid, do some of you know about this? Are there oncologists in the group? The National Cancer Grid is a collaborative of 270 plus cancer hospitals in the country. headed by Dr. Pramesh, who is a director of the Tata Memorial Hospital Center in Mumbai. And in a document called Choosing Wisely India, the link to which again I have given, there are 10 don't do things, low value or harmful things. And please read this. If somebody is willing to read it out aloud, I am very happy. This is what the National Cancer Grid says. The 270 cancer hospitals are party to it. Yet, you know what happens in those hospitals. How people with advanced cancer are kept in intensive care units, lonely, miserable deaths. Again, we'll talk more about it at end of life care. And please don't think that it's happening all over the world. Radha is now in the UK. We are eagerly waiting for her return next month. But in UK, this study is from Europe, not from UK, European Union countries, where 90% of people are taken off the ventilator or whatever artificial life support is given when disease is no longer responsive to curative treatment. When doctors assess, arrive at the futility of treatment, they counsel the families and the patient, and they withdraw the artificial life support and instead give them palliative care. Only 10, it's actually 89.6 or something. Whereas in India, 70% of people go through artificial life support till the moment they die. They have to, their hearts eventually give up. If it's a VVIP, then they are put on ECMO, extracorporeal membrane oxygenator. One of my dear friends, an anesthetist, owner of a hospital, had this happen to him. He had COVID, and as he was dying, he was put on a ventilator, stayed there for more than 42 days or something. And then when his heart was giving up, he was put on extracorporeal membrane oxygenator for another 27 days. And his friends had to take a collection to pay the hospital bill. No, this happens, and unfortunately, in most of the other 30%, what is done is a very unethical, horrible thing to happen. People are said, well, if you want to take him, you can, but say that you are leaving against medical advice. Write down, I will be responsible for my mother's death. People are actually made to write that. They live with guilt for the rest of their lives and sign the document. Then you connect an ambu bag and send him out to die in an ambulance or in a few hours at a home. Stark realities of the country. Friends, our primary responsibility is to mitigate suffering, but much too often we are causing suffering. And that suffering, as somebody earlier said, would be physical, pain, breathlessness, social, including the poverty and relationship issues, emotional, grief, depression, anxiety, guilt, and spiritual. What's the point of my being alive? I wish I were dead. Why did God desert me? That kind of things. So that is palliative care, mitigation. You may not be able to do it completely, but we will have a jolly good try. Try to make the life as livable for the person with some enjoyment, some giving, some taking, being with the family. What can be more important than that at the end of life? Once physical comfort is taken care of, then we are able to give attention to the rest of the person. That is palliative care. I know this is not the WHO definition, but in the second slide, I showed you a Lancet Commission report. This report from 2017 uses this phrase as the catchphrase, the key to understanding palliative care, serious health-related suffering. Before I go on with the WHO definition, I would like to stop the screen share for a minute and with Dr. Radha's permission, take any questions that have come up so far or that will come up.
See, as Dr. Rajagopal has mentioned, you can unmute and ask. See, don't think, oh, my query is very small or how can I ask? Don't have anything like that. This is the best platform. So get that clarified and you will do it because this is day one of your course. Whatever you feel, oh, this is a difficulty or this is not easy to do, whatever it is, you can share. Either unmute and speak or you can type in the chat. Either way is good, but feel free and that you will have the benefit of it.
Yeah, good evening, sir. I am Dr. Kavita here.
Hi, Kavita.
Nice to see you, sir, and hear you.
Same here.
I actually, in this talk, which which I listened to, there's one thing which I realized. You said, I don't want to tie my hands, and somebody saying that it's a chronic disease. Correct?
Kavita, let me clarify. I said that in our country, palliative care should not be reserved only for chronic diseases.
Okay.
Some acute conditions, so-called acute conditions. I was bringing the example of somebody with 80% burns, 70% burns. Some conditions including chronic pain. So chronic pain is chronic, of course, but some acute pains also can cause enormous suffering. And if we are given the opportunity, we shouldn't turn back and walk away from that child with burns, but instead give pain relief and the rest of palliative care.
Okay, so you meant to say it is for both acute and chronic conditions.
Yes, and it is relevant usually, mostly in the chronic diseases context, but no definition limits it to chronic. Yes, it should include acute also. Thank you for asking the question.
Thank you
and
so
giving
much.
me a chance to clarify for everybody. Kavita, where do you come from?
I'm from Bangalore.
Okay.
I'm a family physician.
Right. Shall I take one more question from anyone?
Someone has raised their hand, sir. Chidananda Swami. Please
Yes,
go ahead
Chidananda
and please unmute and speak.
Sir, this is Chidananda. Nice to hear you. Nice to see you, sir. Just regarding this end of life care, what we are mentioning, and withdrawal of life support. With the introduction of this end of life care bill in India, has that made any difference, or is still yet to be understood by the medical professionals themselves? What do you say, sir?
Dr. Chidananda, the end of life care bill that was placed before the Parliament in 2016 never got to discussion. It was put up on the public platform. People were asked to comment, and I understand that more than 1,300 comments were received, including we had also submitted our input, and then they did not pursue it. Every bill that is submitted gets automatically cancelled once a government changes. It is not alive, it is dead. End of life has come for the end of life care bill. But then, in the absence of law, what holds validity are Supreme Court judgments of the Supreme Court. I will not go into the details of it, Dr. Chidananda and everybody, because there is going to be a separate session on end of life care, which will also deal with withdrawal and withholding of life support and end of life care. So pardon me, Dr. Chidananda, that I am not going into details of that today.
No, sure. Just wanted to know, because there's so much of talk going on.
Yes.
Whether, see, one is into the public domain, the general public understanding it. First, the medical professionals should be able to understand, assimilate, and be able to put it forward to the common public. What are the options available? That's what I feel, sir.
Excellent. Absolutely. I totally agree. Here in this case, the medical professionals, unfortunately, often become part of the problem than the solution. Yes,
Yeah.
we'll discuss that.
Yeah. Thank you, sir. Thank you, sir.
Thank you. Unless there is another burning question, I'll go back to my presentation, because I see it's already 5:38. Sri, we have a case presentation today, right?
Yes, sir. We'll be presenting our model case so that everyone can know how it goes. So,
Okay, so I must hurry up, or Priya will throw me out. Sri Priya.
No need to hurry up.
Sri.
You can go in your own pace
Yeah.
and we can do everything comfortable.
Thank you, Yada. No, I am sorry to show this to you. If I were the WHO, I would have apologized for giving a long definition that is 2 kilometers long. I have highlighted some points. As somebody said in the initial question, it's about quality of life. But friends, not only are the patients, but also their families. Everybody knows that when somebody is seriously ill, the whole family suffers. This is in the context of all life-threatening illnesses. According to WHO, the definition is 21 years old. The problem is, you should not define life as only a beating heart. Life is something that should be meaningful. A person with paraplegia shut up inside 4 walls for 365 days, allowed out only on hospital visits. What kind of life is that? Is this a life? So whenever the quality of life is seriously threatened, we will intervene by preventing and relieving suffering, by treating pain and other physical problems, psychological problems, social problems, and spiritual problems. The only quarrel that I have with the WHO definition is, one, it is too long. A definition should not be an essay. Nice and crisp, so that we can remember. But also, the word life-threatening is misleading. Many people take it as to mean only where the quantity of life is limited. That should not be. But that definition also adds this footnote. Who is going to read it out for me? Somebody please volunteer. Everybody is tired of hearing my voice. Volunteer, please. Unmute and read it out for us. Kavita, you are sitting there right in front of me.
Okay, sir. Sure. Thank you. Okay. Along with the, yeah.
Palliative care is applicable. Okay.
Palliative care is applicable early in the course of the illness in conjunction with other therapies that are intended to prolong life, like chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications.
Thank you, Kavita. Everybody, you understood? So, if I get a serious illness, when should palliative care start for me?
It says early in the course of
when my
illness.
Suffering starts.
As soon as diagnosed.
Even in sometimes it can be before the diagnosis, doctor.
Yes, sir.
Right, pain, breathlessness, whatever is the original symptom. But very often people say from the time of diagnosis. That's most of the time correct. But remember, this has to happen along with treatment of the disease. Patients should not have to be transferred to palliative care to get this done, and we'll see later how this can be done. But also there is another point. not like curative care ends and palliative care starts. It's more like this. As the disease progresses, as suffering increases, we chip in hand in hand with curative treatment. But eventually, when the patient dies, palliative care continues as support for the family. This is actually something that we practice, though I know nowhere near adequate, but there is a bereavement support program to follow the patient's death. Now, we said it is physical, social, psychological, social, emotional, and spiritual. The physical points first. I mentioned first specifically, unapologetically. If a physical suffering is intense, it leaves no mind space for anything else. That's so all-encompassing, like pain or breathlessness. When you are worrying, I cannot take another breath. You cannot think of anything else. So often, pain being the commonest of symptoms needs to be taken care of. Unfortunately, it reaches a tiny, tiny minority of people in our country. I won't go into the details of the ladder. This is the WHO ladder for analgesia. I'm not going to it. You will have more than one session on pain management in detail. Specifically avoiding it, I would still say this is essential. The majority of patients that you see, particularly with cancer, but also with some other conditions, will need opioids of step 3 of the ladder. So one of the sessions that you will have towards the end of the course is how to procure it if your institution does not have it now. In 2014, the World Health Assembly, that's the decision-making body of WHO, came out with this declaration. Integrate palliative care into health systems at all levels. That means primary, secondary, and tertiary. Across the continuum of care, that is from the beginning of the care, suffering to the end, 2014. Every 2 years, WHO reviews this, except during the COVID years. Until 2018, the last one in 2018, India had drawn a more or less a blank. But now things are happening. I'll talk about it as we go along. But it can be any symptom. Let me give you an example. It's only an example. I'm giving you an example of breathlessness. How management changes. If I come to you with advanced cancer, breathless, maybe beginning to get cyanosis, please don't rush me to ICU. I need the family by my side, if they're anywhere there. If not, I want you to hold my hand. No false reassurance. Don't tell me everything is going to be okay. I know everything will not be okay. But if you tell me instead, I see you are anxious, I'll do the best for you. We'll try our best to relieve your suffering. That will reassure me immediately. There is a human being who is to care for me. Always remember, whatever be your specialty is, your face, your eyes, and your words, if it conveys to the person that I care for you, my God, it will be such a relief to the person. I would tell them, I'm going to try the oxygen mask on you. If it helps you, we will continue it. But whether it helps you or not, we will know in 10 minutes. Actually, it takes less than 7 minutes. For equilibration of inspired oxygen with arterial blood, at the most, it takes only 7 minutes. If it does not help, what's the point? Oxygen that does not help in relieving breathlessness, even if it increases saturation by 4%, what the hell? In an advanced illness, it is pointless. It's very uncomfortable. But if the person gets relief, he'll say, give it to me, give it to me. The two medicines in that context, say a lung, that may help most are corticosteroids to reduce the peritumor edema and low-dose morphine to decrease the sensation of breathlessness. It's almost like a miracle. I know every anesthetist here, maybe every neurologist will be thinking, but morphine causes respiratory depression. The same depression that will occur with severe high doses, in tiny doses, by easing the respiratory center, will reduce the respiratory drive, will make the person breathe slower, and then the breathlessness will reduce. It dramatically happens. So from what I have said so far, Sri, you are not running a poll, are you? I didn't give you a warning in advance next time. But what do you think? Just give this a thought, even if you don't answer. My own answer is B. When pain or suffering starts. If you put A also, I will not quarrel with you. But if you say C and D, we are going to have a big fight here. We will start palliative care along with diagnostic and curative efforts when the suffering starts. And that can be in any of these fields. I talked about physical suffering and 2 symptoms, but all this needs to be addressed. Which can happen only if you integrate palliative care at all levels across the continuum of care. That means Dr. Malay Kumar, what's your specialty?
I am not a specialist yet. I am just an MBS.
Okay. Thank you, Dr. Malay. Shikha Gupta, Kamakshi, specialty or GP?
Good evening, sir.
Good evening.
Dr. Kamakshi, sir. Nice talking to you. I am an anesthesiologist, sir.
Anesthesiologist.
Yes, sir.
Dr. Kamakshi, palliative care should be part of your anesthesia practice.
Yes, sir.
Integration of palliative care into all healthcare means when Dr. Kamakshi in the morning sees a patient, she, instead of talking brusquely, lays a hand on the hand and tells the patient, I'm going to look after you all through surgery. Those words start the process of integration. And then you will make sure that the patient has no awareness during surgery that your work does not end with the operation. That you make sure that the postoperative period is comfortable for the patient. You get involved in the pain relief. The bulk of palliative care, therefore, is to be done when palliative care is integrated into healthcare. Dr. Shivakumar, can I ask you what's your specialty?
Nephrology, sir.
Dr. Shivakumar, more and more is talked about conventional conservative kidney management. You know that the minority of people with chronic renal failure in our country can access dialysis, leave alone renal transplantation. Today, the health system is practically rejecting all the others. From the beginning, patients should be given the option of conservative kidney management. Fortunately, in India, there's a reasonably strong movement that's starting in that matter. So whichever specialty you are in, pulmonologist, cardiologist, whatever, the bulk of palliative care delivery will be by you incorporating palliative care into your routine work. And specialized palliative care units like ours can take care of only the minority. If Dr. Shivakumar finds that despite what he is doing, such and such a problem of the patient is not getting adequately corrected. The patient continues to vomit or something else happens. Or you can imagine how busy and a good nephrologist in our country will be. He just doesn't have the time to keep following up. Then he may refer the patient to us. And in all this, if you are to address the social, emotional, and spiritual issues, professionals cannot do it alone. We need participation of the community, non-government organizations, willing people, willing to support them. And this integration has happened in the national policy up to a point. 2017 National Health Policy already includes palliative care. If you are a hospital superintendent or the director of a healthcare institution, you may have the power to integrate palliative care into the whole hospital. But nobody is so weak as to do nothing. If Dr. Imtiaz or Dr. Vaishnav or Dr. Purnima, whatever medical profession field you are in, you integrate principles of palliative care, that's also valuable. That would be the micro level. But Dr. Purnima and Dr. Vaishnav and Dr. Imtiaz, are you wondering, oh my God, already I'm so busy. How can I do this? Please understand that's a normal reaction to change. You are intimidated. We'll work with you to make it happen. Deal? Imtiaz, Vaishnav, Purnima? We'll work with you to do little things which make a lot of difference to people. Sometimes people will get angry. You go and tell you to say this to the dean of your institution. You young man, who do you think you are? Because they may be feeling threatened. But as you practice it, you will start enjoying this. And as you keep doing it, there'll be some people who are ready for change and will join you. Where a lot of people will say, Vaishnav is crazy. Look at this man wasting his life. But some people will join you, and you need to keep working with them so that that line shifts. Gradually, more and more people will join you. If you waste time fighting these people, you will be exhausted. Just walk away. As I said, many things are happening in the country. The National Program for Palliative Care, the change of the law in 2014, improving access to opioids, inclusion of palliative care in the National Health Policy, and palliative care is now in the undergraduate medical and nursing curriculum. You will hear more about it during the course. For everyone working in a teaching hospital, please give attention to this. We have a team working only at empowering you to teach it to undergraduate students. Our team, led by Dr. Sridevi Warrior, has created all the relevant modules that are relevant to palliative care. And we will work with you. But what we also now have, which you can share with all your friends, is a massive open online course. Now you have to come and sit here from 5 p.m. to 6:30 p.m. For those who do this person-to-person interaction may be minimal, but you can do it people can do it at their leisure. In Kerala, our university is working with us to get this implemented all over Kerala medical colleges. I'll stop there. We have a few minutes for questions before Radha gets on with the case presentation.
There is just one small thing in the chat box which I will read. As a beginning, and this has been written by Dr. Chidananda Swami. As a beginning, can this be made a part of anesthesia training curriculum, like the other subspecialty training?
Yes.
I think
One
he's
word
asking
answer is yes.
palliative. Yeah.
One word answer is yes, Dr. Chidananda Swami. In the new curriculum from 2019, the way palliative care is included is with a series of steps in the foundation course itself. Then many things come up in pharmacology. Some things come in, a lot of stuff comes in community medicine, but most pain management happens in anesthesia. So in the curriculum that I talked about, that is the National Medical Commission's competency-based curriculum. These modules, sorry, let me show you. These modules that I talked about are distributed all through the course. All through the course, 20 modules. Some of them are in anesthesia. But what happens in the majority of colleges? Do you know how many medical colleges are there? The last time I Googled, it was 680. Must have gone up by now. Most of these medical colleges will not have the time or inclination or knowledge to teach it. So, Dr. Chidananda, if the anesthesia department takes on this responsibility, I'm sure other departments will also be pleased to accept your help. So, yes.
So one question from my side.
Yes.
Maybe excuse me for this question, because one slide you said palliative care starts at the time of diagnosis when the pain or suffering starts. You said A and B are the right answer, but the third one you said if it is an incurable, we can have a small fight, maybe a happy fight. So incurable, I want to understand, why can't we add that incurable? Because I'm coming from this understanding that there are diseases which are curable. For example, an appendicitis. When you do a surgery, the pain stops, post-operatively patient gets better, and that is done. Or a renal colic if a stone is treated. So some of these diseases are curable. And it is, I think, majorly those incurable diseases where it is those conditions where the suffering is prolonged, where the pain is prolonged.
You have a point. Certainly, in incurable disease, it has great relevance. But Kavita, think about cancer. Today, the majority of 2/3 of all cancers are curable if detected early and if treatment is available. But how long does the treatment go on? Sometimes more than a year.
Yes, yes.
And that period is usually filled with suffering. And at that time, palliative care should go along, hand in hand with everything. From the time of disclosure of diagnosis, from the time the oncologist has to say, you have cancer. And then all through the chemotherapy, surgery, everything, this has to go hand in hand. I took the easy example of cancer. Even if it is not so long as this, it would still be valid. As I said, 60% burns, maybe curable. The process will take 3 months. And so many skin excision of scars. Oh my God, that's the worst kind of suffering, one of the worst kinds of suffering that I've seen.
So I also want to ask a question. So there was this, am I audible, sir?
Yes, you are, Shiga.
And so just like a slide was shown about breathlessness, and we were discussing if the patient is so sick, he's breathless, and we say we should not be putting the patient on ventilator, just give oxygen. So will it suffice? Is it not a palliation for the family if the patient is being put on the ventilator, and it gives time to the family to think that, yes, my patient is pain-free now. There is some time for that family member to decide what to go further. I'm just getting confused.
Yeah, understood, Kamakshi. You have a valid point, no doubt. Kamakshi.
Yes, sir.
if I am the patient before you, as I said, palliative care is not only for me, it's for my family also.
Yeah.
But first it is for me. Yes, the family will get some time to get used to the idea. But you said pain-free? Kamakshi, you are an anesthesiologist, right?
Yes, yes, sir.
Having a tube down your throat, what comfort can you expect there? Every bit, the muscular pains that will follow prolonged immobilization in a particular position, the agony of a suction catheter. I am an anesthetist, I have been an intensivist. A friend of mine who went through one day on ventilator said the worst experience in his life was the suction catheter going down his throat, through the tube. And Sri Priya kindly, and Radha mentioned my book. And there in one chapter, I have shared a real life story of how a person who had an accident went through the period of suffering and what difference pain management made. But you have a point. An abrupt ending is not easy for the family at all. But first take me into consideration. But also think about my family. Don't subject me to prolonged suffering just so that their life will be, say, shade easier. So what's the answer? The answer is, as we said, palliative care, including communication, how bad news is shared, how plans are made, how care plans are made jointly. All has to start early, which is what we will all do together.
Thank you.
Just one thing, no, like as in the presentation which doctor shared, no, it's not like one box of palliative care, one box of curative care. So what we generally say ideal or best would be is it'll only the percentile variation. For example, when the patient comes and in the process, so that time if he's in pain relief is given. So palliative care may be 5%. Diagnosis, all that is going, they may be 85% or 90%. So that percentage only varies. That's why if you see the graph, so in one itself, you have both palliative care and the curative care. So this percentage variation, curative care might be 85%, 90%, and palliative care just pain relief because maybe if we say even in the stage of diagnosis, something like that, it's going on. But as it progresses, so the percentage, and now we also say it's just not even one line, it may be an undulating line. It may be sometime high percentage of curative care, less of palliative care, then suddenly palliative care. See more symptoms. They have nausea, vomiting, as effect of chemotherapy or anything. All symptom care has to be taken care. And one more thing from the discussion that everything is done in the patient's best interest. We have family, everything you have, but your main person is the patient, and you have the family also hand in hand with it. So if you take like that, both will be taken into consideration, and ultimately the patient gets the best. So understanding in that way may be helpful. And there was one more thing in the chat, sir. I'll just read that. In spite of straight talk with families of non-salvageable patients, many still want to put patients on ventilators, probably to cultural and social issues. Hence, our data varies from West. For this, now, as Doctor mentioned, we have an entire session on that, in which you will be taken step by step with all of this. I still hand over to Dr. Rajagopal to answer his views on that.
I think we cannot afford to go into that now. Anyway, we will have enough time. It has to be discussed
yes.
in detail. And Parvati, totally correct. A child born with a cerebral palsy, for example, serious cerebral palsy, or a congenital defect, or a musculoskeletal disease, will need it for the whole of lifetime. Sanoop says, Oh my God, in spite of all that I said he has rejected all my definitions of palliative care. Sanup, I agree with you. Someday, there'll be no specialty of palliative care. As Dr. Robert Waycross, my teacher, used to say, palliative care is just good health care. To be integrated into all healthcare. Thank you. Radha, you
We'll
are
go
going
ahead
to
with
have
the
the case presentation,
yes,
right?
we'll go. Yes. We'll
Radha, may I leave?
Yes, sir. We
Okay.
are going to take them through. Anybody wants to ask anything or anything burning you want to ask? Otherwise, the whole 20 sessions we will all take you through. And as we have been mentioned, we'll take you through not only now, through your practice also. Thank you, sir.
Thank you, Radha. We come back soon.
Awesome.
We are waiting for you.
Yes. I've already
Okay.
booked my tickets and
Okay.
Thank
See you soon. Bye.
Thank you,
Bye.
sir.
Thank you very much.
Thank you, sir.
Okay, next what we're going to do is we're going to go into the case presentation it's like a sample or like a case how you all have to go through. Okay, so this will be like a sample one, which because case presentation mainly has two elements. Okay, one is an opportunity for all of you to bring in cases, and case presentation is what will make the whole topic discussion more clear, and anything live cases are what bring up all issues. We say physical, social, psychological. When you have a case with all of them, and it will kindle more queries and give answers, and different opinions can be shared also. So it will be the best way forward to move in such a way. For that, we are giving you an example. Okay, let's go through. Next slide, please, Shripriya. Okay, here what we are going to do is we have a 39-year-old male patient. Diagnosis is traumatic quadriparesis with stage 4 pressure sore on sacral region and left gluteal region. Next slide. And he has the main presenting complaints are constipation for 2 days, bed sore over the sacral region and gluteal region, moderate pain over the hip region, and urinary leakage. Next slide. History of illness. He had history of fall while carrying weight, followed by neck pain and weakness of both limbs, and was diagnosed with traumatic quadriparesis in August 2015. Then he was admitted and got treatment from one of the government hospitals and discharged after 1 month. After 6 months, he developed a bed sore over the sacral and gluteal region, and the stage of the sore was stage 4. History of pain over the hip and wound site for more than 2 weeks. Pain over the hip region, pain score was 5/10, and the nature, it was an intermittent burning type of pain. Bilateral wound site, also the pain was there, and it was continuous throbbing type of pain. And due to this, sometimes they've even tried keeping the wound open because the intensity of pain, 4/10, 5/10 it has been. And that has also affected his sleep. So he had disturbed sleep pattern. And next thing, that decreased his intake also. Go ahead. On examination, he was conscious oriented, temperature 98 degrees, pulse 82 per minute, respiration 20 breaths per minute, and blood pressure was 120/70 millimeters of mercury, and all other systems were within normal limits. Next one. Regarding the pressure source, warm and tender to touch, exudates present, tunneling was also present, and the sore itself was irregular in shape, and there was foul-smelling discharge. What was the treatment and investigations done? All routine investigations were done, and like hemoglobin, white cell count, and all like hemoglobin 10 grams, white cell count 34,000, polymorphs 80%, lymphocytes 18%, eosinophils 2%, and platelets were 1.6 lakhs. And the serum creatinine also has been mentioned. Okay, next, what were the psychosocial aspects? as mentioned, he was a 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling who's married and living separately, and that sibling was not caring and helping them. He was a manual laborer and he was the breadwinner of the family. Because of this accident, and now his mother has taken up a work, which is the manual labor, and she is taking care of him because now she has become the breadwinner. So the main source of income is from the mother's daily wages, her pension, and whatever their friends could help. They have taken a loan, 1.5 lakhs from private finance bank for the treatment purpose. And basically they were Christians, but now with their condition, no, he is unwell, mother is the earning member, they are unable to go to church even. And this makes them very sad because psychologically it is causing more sorrow for them. And at times what the patient says is what is written here. He says to his mother, I don't think I will be able to walk, so please don't spend any more money on me or on my treatment. That may not be useful. So now, what are the main concerns in this case? He has pressure sore, we saw, which is large, foul-smelling discharge. That itself is causing so much discomfort. And then the next thing is pain. Above all, this is the financial problem. Okay, so these are the main 3 points of concern. Next, to summarize, a 39-year-old man with traumatic quadriparesis with bed sore present over the sacral and left gluteal region, which is graded as stage 4, and he has pain over the hip region also. Next. So what are the main discussion points? Do we need to provide palliative care for this patient? What are the problems faced by this patient? What all can be done for the patient and his mother? This is the last slide, isn't it, Sripriya? Go back to the previous slide once again. Okay. So we have 3 main discussion points here. What we'll do, we'll come just all of you, if you could have a look at this slide once again, so that we will go in detail with each one. So do we need palliative care? What are the problems faced and what all can be done? Okay. Supriya, if you could come out of this so that we can have, thank you.
Before entering the discussion, just a humble reminder that these are just sample discussion points. Because many a times what happens is we share one sample case and then everyone comes up with these 3 basic points. So please do understand that these are just the basic discussion points, and we need the discussion points to be more specific, more related to the topic which has used. Over to you, ma'am. Sorry for that.
Thank you. Oh, no, very important. See, 30th course. So how many you would have seen? Your value and opinion ideas is equally important, Sripriya. Okay, as we said, similarly, this is just a sample case, as I said. Like all these sessions, you're going to have topic. So you bring up cases which are related to the topic. See, that will be very, very important. And the beneficiary, as I said, always best interest of patient. Now, come on, the beneficiary is all of you. You want to learn the best, you want to get the best, then what should we do? We should bring up more queries. So, as mentioned, depending on the topic of the day, bring up cases. See, either what cases you're seeing now, well and good, or you've even seen before. Anything like that is also fine. So main thing is that if you have some cases, you will have real time issues brought up in those cases. So that will be the best way forward. So this is, as mentioned, it's a sample case. See, we have given you an idea how you go about. And that is also part of your assessment. Okay, all of you have to ideally bring up cases so that it makes or brings interest in all of you also to do what you want. Because at the end of the day, what is that? We all of you should be able to practice and render the service. Okay, so in this, as we say, the first, just to see, we'll just take it like a discussion also. Is palliative care, is there anyone who's, what is your take? Does he need palliative care? Or anyone, is there anyone disagree? Some people are typing as yes. So is anyone disagreeing that he doesn't need palliative care? Okay, so that is one thing. So like that, for this being a sample one, that is one question. And then what are the problems that he's facing? Multiple things. Anyone can unmute and say, if anybody who wants to unmute and talk, please do.
Pain, pressure source.
Financial burden.
Yes, psychological and financial. No, he was the breadwinner. Now he is a young man. Now his mother, who he would have been looking after the mother. But now the whole thing, no reversal of role. Instead of him looking after the mother, now he would have thought all through, I will look after my mother. But now it has become totally opposite. His mother has to look after him. She's old. She's unable to do. But still, she has no other choice. So psychological and financial, both are there. So which has to be dealt with. So that is where multimodal management is what will help. It's not one person. For example, palliative care service itself can be broadly said as, it could be that's what this micro, meso, macro, all what Dr. Rajagopal explained this. It could be a hospital-based palliative care or a home-based palliative care. Both are possible, and both may be needed to tailor the needs of the patient whom you're dealing with. So if it's a inpatient hospital care, all under one roof, you may have either the treating person, physiotherapy, psychologist, counseling person, everyone will be under one roof. Okay, social workers play a very big role. Whereas if it is going to be a home-based care, so one home care team may not have everyone. So, but we say generally basic, at least 3 people are needed: doctor, nurse, and the social worker, because that is the bare minimum, we say. Because see, a lot of issues have to be not only physical, we have social, psychological issues. Here, financial issue. There, a social worker or person may be able to link them. Here, these people need some support. There may be an NGO who is willing to help, but he doesn't know whom to help. So the social worker could be a link between the patient and that NGO. So those type of things. Somebody has typed holistic approach. That is what we are coming to. That is what will be successful. And Parvati Nair has mentioned, for the patient, lack of knowledge about his prognosis and possible mental health issues. Yeah, exactly. That's where awareness. So both for the patient and the carer, together, we have to raise awareness. Slowly, and all these don't happen in one sitting. So, and as we all go through, you will be going through different aspects. One of very, very important one is communication. How are you going to tell? How is the patient going to receive it? And you say something, and then what you have said, has it been understood very well by the patient? That also it's our responsibility to make sure. You say something and the patient has not understood at all. You can't assume that the patient, whatever I said, he has understood. Not everyone, because when they are in pain and the situation, see, sometimes when we reveal something, it might cause a complete block of them not even able to think, because it's a very strong, serious, sensitive issue or topic that you're telling them. So those things are important. What you're telling, have they understood, have they digested, and are they able to take it? So give some time, and then you have to ask them, are you clear and have you understood? If they say they've not understood, it's our responsibility to explain in more detail, put it simple, put it across. So they're also aware, raising awareness, conveying the message. For that, communication skills are very important. So you have few sessions on communication. So that's why at the end of this, it's a very, very well structured curriculum where you will cover all the essential elements, and you will definitely be in a better level to be able to render the service. Okay, and then the third one was the issues both by the mother, son, and the financial issues. As I was mentioning, that is equally important. We can try and see, not always possible, but there are ways and means of helping them. So here it is the mother and the son. Sometimes it might be a very young family. Education becomes a very important thing. And that will be their main worry, isn't it? So like that, it varies based on the particular case. So that is how we have to deal with it. And so this is just an idea for all of you to know how to go about. So whichever, you've got a wide variety of topics. So pick and choose and send your cases, whatever you have in your work area, so that based on that, see, whatever you bring up will help you to have a nice, healthy discussion. Okay, and that one I will leave it to all of you to bring cases where you feel comfortable. And as I said, you've got a wide choice. 20 sessions you've got, like 1 or 2 sessions alone, we don't have a case because that like may not be appropriate for you to bring. But other than that, most of the topics, Sri Priya, you will be sending them a link, list, isn't it, for all?
Already shared, ma'am, and we have received around 4 cases as well.
Very good. That's well done to all of you already. See, keep on doing, and you send the cases, and then on the day you be available to present, because next thing that is important, because only when you're available you can share what are the actual problems and issues which is there, and then it'll be a good session for you also, because you will get so many probable options and solutions which can help the patient. So that is something which could be helpful. Anything else anybody wants to ask about this case presentation? Any doubts or how to go about? And also, like with the first preliminary thing, before the topic discussion of the day, anything what was told to start off, any doubts in that also? Joining in, how do you come, all that, anything, any doubt with that also, please, if you have any burning queries, please do ask. Let me check the chat box once again. Thing more new is there. Okay.
Just to add on to what Dr. Radha Venkateshan said, our basic idea is to improve the knowledge level. Like whatever things we are teaching, our faculties, our eminent faculties will be sharing with you the basic principles of palliative medicine. And whenever you are bringing in the case, the real scenario comes in. So that each setting will be different. Each one of you are from different places, so your settings will be different. Before I continue, Dr. Chidananda Swami, I see your hand raised.
Regarding this case present, do we need to send in the case details earlier, or on the day can we present it, or I just want
Actually, sir, the last day to submit everyone's case presentation is tomorrow, 20th. We ask that specifically because there is a panel, there is a faculty panel, expert panel who goes through all these cases, who then suggest if any more discussion points are to be needed, if any more details are to be collected or not. Then if multiple participants are sharing cases on the same topic, they will be choosing which case is to be presented during the session, and the remaining cases will be considered for evaluation. That is why we request everyone to send in their cases at the earliest possible.
So, sorry, I missed it. I had missed it out. Can I just take a day or two to submit it, please?
Yes, sir. Then on a case-to-case basis, yes, of course, we can consider that.
Okay, thank you. Please.
Yeah, I think some more have not been aware that tomorrow is the last date for submission. Like that's what. See, please do send in the cases, because many things is that one is evaluation, another one is more cases come, it will be helpful for you. And again, as I said, case related to the topic is what will be more beneficial. Okay, that is what we try to, and the panel will try to get what is the best for that topic. Okay, that's all, nothing. And every case, whatever you send is important, valuable. Somebody wants to say?
Any format?
Yes, go ahead.
Any format for sending the case history, madam?
Whatever we have used today, that maybe Sripriya, you can send
it is
this
already
format.
Shared in group. You can go through that, or else you can just send a message, direct message to us. We will share it with you.
Ma'am, can you share that again, because I think I missed it because I joined a little late.
Yes, after this session, I will share the template once again.
This presentation. Thank you.
That will be helpful. That's all. So pick up cases, whatever, anything what you have or what you have had before, no worries. Okay, which appropriate to the topic will be helpful, and as we go, you yourself will see that how much of benefit case presentation brings it. Okay, and there was one thing, one query about attendance, Sripriya. 1 minute. It was
can be more specific, like what aspect of attendance?
That's all. I was about to ask the same thing. What? I'll see who was it. Was Anup Yadav. Anup and another person also. Both of you, if you ask what is your query.
Best interest of time
that's what. And then one more thing, the topic present.
Dr. Anup had said how we mark our attendance. Actually, once we have switched to the IECO platform, the attendance marking is completely automatic. Once you log into the session using the unique link received in your WhatsApp, email, or SMS, your attendance gets marked automatically. So there is no need to
Okay.
And topic presentation is theory. What is that?
We may need more clarification on that question as well.
So just what I would like to explain is, for example, if pain relief or vomiting is like the topic of the day, your case should be dealing with something. For example, if it's vomiting as the main issue in a person who is having palliative care issues. Okay, so that is how we are looking at it. Should be a topic of the day as the main issue in a patient who is having palliative care issues. Okay, so that is what, from whatever that query was, even though it was not clear, what I thought I will explain is that. So that is how each day, whatever is your topic, your case presentation should be related to that topic. If more than one attendee are joining together, Priya, I think for attendance, the next query is.
Okay. If
You have
more
mentioned
than one
all-
attendee are joining together, of course, the system will not fetch both the names. That is why we said in the beginning itself that if two people are logging in, please do remember to log in using your individual devices and individual login IDs. Of course, if you are using your office, your organization devices, you can keep the mobile one person's mobile device on mute and video off. That is okay, completely okay. But then if you want the attendance to be captured, the login should be unique. Two people should definitely log in from different devices. That is what we strongly suggest, because this is an automated process and we have no control over that.
Okay, is that all clear now?
Dr. Shreyasri, like I'm not like I'm confused how you joined using the Zoom link. Of course, it is a Zoom link class, and what happens is the unique link which you receive will not have the words like Zoom and all. It would be a clickable link, and once you click that, it will automatically redirect you to the Zoom platform. That is how it happens. So if you have used that provision, of course, your attendance will get captured. But in case you have any doubt, please do get back to us tomorrow, because attendance takes 24 hours to get updated, and we will definitely check it out.
Any technical issues or anything like that, get in touch with the technical team. They will help you.
So every day, every class will be sending a link, is it?
Yes. Pardon, sir?
Every day, for every session, you'll be sending a separate link where we.
Yes, sir. The link will be different for every session, and it will be shared to you automatically. The links are generated automatically, and it will be delivered to your WhatsApp, SMS, and email. All three medias.
Thank you. Thank you.
And these links will be generated and shared only 30 minutes before the session.
Do we need to type the summary also of each session? Like
No, ma'am. No.
WhatsApp.
Like once you have attended the class, there is no need for that. That option of sending in the summary is for the 20% class. If you are missing any session by chance, if, because of duty or anything, you are missing a class, if you are sending in us a summary of that missed session, after going through the recorded session, we will update the attendance. That is how it goes.
That summary has to be submitted in 24 hours, within 24 hours, or can it be done later?
Before the next session, basically.
Before the next session. Okay, thank you.
Okay, I will hand it over to you, Sri Priya, then. I think there's no more.
Dr. Shreyasri, yes, attendance is shown definitely in your IACO account in coming days. Maybe in 1 or 2 days, I will definitely be sharing the details of that also in WhatsApp group. How to fetch your attendance, how to watch that, how many sessions you have attended. All those are accessible to every participant by logging into their unique IACO account. So I will be sharing those details as well with screenshots in the group in coming days. And just reminding that we have now opened the group for all to communicate. Earlier, because of the fear that many would not be able to join, or many would be facing technical glitches, we had made the group admin only. Now the group is open to all. Please do make wise use of the same. So we have kick-started our journey of 20 sessions today of the foundation course in palliative medicine, and looking forward to have a very wonderful, interactive and informative journey with a lot of eminent faculties, experienced faculties joining in for each session. This is Sri Priya along with Dr. Ratha Venkateshan and Mr. Anup signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you. Good luck to all of you.